Hi, everybody, and welcome to this month's UEFA medical webinar. And this month, we're going to talk about syndesmosis injuries, more clinical, more medical than previous webinars we've had so far. But I think very, very interesting to a lot of you. Today we have two speakers. First of all, Pieter from Aspetar, orthopedic surgeon. Welcome, Pieter.
Thank you.
And we have Adam Johnson from Everton FC. Welcome, Adam.
Thanks very much for having me.
Awesome. We're doing a little bit different today. You two know, the audience doesn't know it yet. We have one presentation instead of two separate presentations, and we rely a little bit on the people on this call to have a lively discussion with us on the topic of syndesmosis injuries. So I'm going to give the stage to Pieter in a second to guide us through the 4 common questions he gets from our audience, to start up some thought-provoking ideas out there that we could discuss further. And then after that, Adam and myself will be back. So I invite everybody to put questions and comments in the comments box on the YouTube channel, and then we'll see them, we'll pick them, and then we will have a moderated discussion afterwards. So don't be shy to ask your questions. Anything is possible here. So as long as it's around syndesmosis injuries, of course. So for now, I'm going to say goodbye to you for a few minutes, Adam, and see you soon. And then it's just me and Pieter. Pieter, thank you for being out here today. You're going to start by giving a brief introduction on the syndesmosis injuries and the 4 main questions you get, which go from how big is the problem to diagnosis and rehabilitation. So I'm going to get your slides up here. Here they are. And I'll be gone for a few minutes, and the screen is all yours. See you in a second.
Thank you, Evert. First of all, a big thanks to Zoran, you, Evert, and Kat for the honorable invite to discuss our insights, especially football related to the return to play and syndesmosis injuries of the ankle. It's a pleasure to team up with Adam as well. So with that, I just want to say that I have no disclosure to this talk. And as an introduction, I want to correlate the syndesmotic injury with the 3 musketeers, because it's basically something that is related to serving our athletes, but also making sure that we understand it in a way that Dumas wrote in his book as well. I'll get back to you on that. Basically, a syndesmotic injury is a lateral complex injury where the ITFL, the IOL, and the PITFL are involved in. So when we take that a little bit further, the athlete that comes into your clinic, as Evert has already instigated the discussion, has 4 questions. So, Doc, what do I have? What do I have to do? What's the time to get back? And if we're lucky, we get a 4th question, and then it's on the prevention of re-injury, not to have the same problem. And with that, I remember about 9 years ago, I was in clinic, and the presentation as the so-called expert on ankle, the athlete comes in and asks these 4 questions, and I had to blush on my cheek saying, look, this is what we think it is, but it's not backed up with proper methodological science on almost every 4 of the questions. So this was a little bit the journey that we took to at least serve the questions of our athletes better on that syndesmotic injury. And everything started with the publication we did on the fact that we had a crazy idea that every acute ankle referral, we were able to do an MRI and see what happened. And we basically saw that 20% of athletes referred for a lateral ankle sprain, call it, they suffered combined or not combined from syndesmotic injuries. And that is, of course, an interesting thought for the simple reason that an ankle sprain is an inversion plantar flexion injury, but a syndesmotic injury is a dorsiflexion external rotation injury. So the mechanism is completely different. So that means we don't really understand what's going on. And I'm happy to take you on a journey of what we tried to get some clarity in these questions. Now, the first question is, what's out there? And if a few years ago you would look in the literature, you would see that basically, apart from some collegiate athlete articles in the US, there was nothing. So we just were able to team up with the UEFA database under the leadership of Jan Ekstrand and the whole team, and we were able to classify a little bit more the insights on what's going on there in professional football. And if you look at the numbers, this is in a cohort of 3,500 plus players, all from Champions League level in the European elite football stage. And what did we see? We saw that the injury incidence during match play was much higher. So it happens mainly during match. There is an annual increase. I think we can discuss that, Evert and the team, because obviously we see that with a lot of topics in the database that has more to do with awareness, with the fact that we document it better and better, but we do see that annual increase. So it is something that is becoming more and more. And most of these injuries are contact related. So it's not like they get stuck only by their own in the ground with the cleats and have the injury. No, 2/3 of them are contact related, and the absence from play is much more than a classic ankle sprain. So that is basically what we saw at first. And if you look at the data that we gathered from the World Cup with the team, you see that about 23% of the referrals we got during elite football from a world stage is on foot and ankle. And most of them are just like in the knee, referred to ligament compared to muscle and tendon in the thigh. So foot and ankle is number 3. Ligament is the primary candidate of having issues there. So that's a little bit, in a nutshell, what question 1 embodies. Now, what do you have to do? Now, here is your athlete with a syndesmotic injury. It happened acute or a few days after, and you say, Doc, basically the question will be, is it bad? And do I need surgery or not? That is what we get. Obviously, everybody in its own biotope has different types of questions, but this is what we encounter, and this is what many of us encounter. And then the question is it bad? Well, we like to keep it simple. There's 3 grades. There's grade 1 that is never surgical. There's grade 3 that is always surgical. The fun thing is that most of them, about 83% of all injuries that we see coming into our clinic from football-related potential syndesmotic injuries are grade 2s. And that's where it becomes interesting, because that's maybe surgery. So, or you will treat them all conservative and you might miss the window of opportunity to have surgery and be good, or you will operate all of them and about 60% of them will not have needed the surgery. So that's where I want to take you a little bit further. But basically what it is something that we have encountered as pathognomonic tests. If you go for an arthroscopy, as you can see below, you can actually differentiate stable from unstable injuries. But my message today in the elite football stages, be very careful with just the classifications, especially on the grade 2s, for the simple reason that they always present differently. Here you see, for example, a patient from a national team player that had a Weber-B fracture, undisplaced, and said, I want a second opinion. And long story short, we always do an arthroscopy, and we see that this is, for example, a ligament floating injury where there happens to be broken bone, not the opposite. So we look at the ligaments. And there are 2 mechanisms. The mechanism 1 is the one you see on the left. It is the Wolverhampton player, where you get stuck, dorsiflexion, external rotation, and a syndesmotic injury. The second one, and the more devastating one, is the one where our attackers are tackled from behind. They get stuck in external rotation between the legs of the scissoring defender, and that is where you have the most of the time combinations with fractures as well. Now, when we talk about fractures, this is the candy to the orthopedic foot and ankle surgeon. It looks bad, but basically what you do is you fix the fracture, you reduce the fracture, you treat the cartilage, and then the syndesmosis is stable and should get better. But sometimes they occur in different stages. They occur through ligamentous problems, but also through avulsions, as you can see here. And my message for today is that it should be very important to know that when you have a Weber-C fracture, which means that the fibular fracture is higher up, you have 100% syndesmotic instability. That means that you have to fix it. If you see the case here, you see that it was fixed, but the syndesmosis was not treated. And look with me on the medial side of the talodome. You see the radiolucency. You see already the cartilage being the next victim of that, call it instability that was not diagnosed. And with the devastating cascade of cartilage problems that could have been avoided. For the Weber B, it's 50%. So important to know that cartilage is a big part of your concern around syndesmosis because of the shear forces and the rotational instability that adds to that. Now, with that, we were able with the friends from the Amsterdam group to now finally map that. To our big surprise, every syndesmotic injury isolated from a ligamentous point of view has 1 out of 5 has cartilage lesions, which is new and which is, of course, a big concern for all of us, because as you can see, types of injuries still come into our clinic like this that could have all been avoided. And I have to acknowledge that never forget that there's something called like a mesonerve fracture, where you can see that, for example, here on the AP, you would have missed it. On the lateral, you can see that there's a fracture. So that guides you, not only the mechanism, not only the clinical presentation, but also the X-ray can already guide you very much into detail on how to treat them. Now, we still nowadays see referrals like these, where although we know how to put the fixation in, and I don't want to be too technical, but for example, this is a case from last week referred to us with problems of infection and so on. But long story short, the suture button is exactly in the fracture. So this can never heal, and this needs to be avoided in the future. So we really have to use the stages of education globally in order to not only understand the problem, but also standardize our level of care. Now, what do we do in the world? Because we talk about European football, but with our group of the ISAKOS foot and ankle worldwide, we did a survey on to see, linked to the injury of the syndesmosis severity, what do we do? And surprisingly, or maybe not, we have seen after reviewing with 800 foot and ankles experts in the world that most experts do not alter their rehab protocol based upon the injury severity. And the results of the survey suggest that while there was consistency among responses at the individual level, that was not the case at the inter-respondable variability. So return to activity for athletes with syndesmotic injuries still is not standardized. And that's why we were on a mission to get a bit more detail on that. Now, I need to tell you before we go to the return to play, which is question 3, I need to tell you there is now a wonderful Munich classification that really covers it very well. You have the intact one, grade 0, you have the AITFL grade 1, and then the grade 2 to 3, where AITFL, IOL, and PITFL is involved. I don't want to go into much detail, but what I want to say is that until now, we're all focusing on the lateral, but the key to syndesmosis is the fourth musketeer. Never forget D'Artagnan, because the deltoid has a big role to play, and I'll try to show you why. Now, when you look at the deltoid itself, it is some restraint to the posterior translation of the talus. It has reduced joint contact areas with more cartilage problems if it's not well aligned, and you can have these soft tissue interpositions of the deltoid into the medial gutter that can, after healing or fibrosis, give a lot of problems to the players as well. So when you talk about deltoid, the repair is something that helps. I've found some recent literature showing that the key in the deltoid, you know, there are 4 ligaments in the deltoid, is the tibiocalcaneal tear. If you have a tibiocalcaneal tear, that means that is a coverage of 2 joints, the tibiotalar and the talocalcaneal. And then you become into an unstable area where you cannot cover that with physiotherapy only or podiatry. So the key here is look at the tibiocalcaneal ligament in order to know if you need surgery for the deltoid or not. An example from 2 weeks ago in a Champions League player, You see here a deltoid injury and the talar insertion and the tibiocalcaneal injury is completely exploded. So with that, don't just focus on the anterior part, which many do, but really look into that central part as well. Another study I found shows that the repair of the deltoid in these cases produces better results than letting it heal towards fibrous healing with immobilization. And because of that and doing the repair, you obviously can link with shorter return to sport compared to the non-repair group. So that's a little word on the deltoid. Sometimes we see these terrible cases where revisions have shown there's no more tissue left, and then we use grafts. This is a photo from my partner that did recently this case. It's a bit spectacular, but if you look at the left video, you see that this is pre-op, where on the right ankle you have a complete collapse of that tibiotalar and subtalar joint, where 3 months later, this is the recreational athlete. And you see that even going very heavily invasive, which we normally never have to do, but in these salvage cases, you can find results where you get stability back and where, let's say, athletic care can be found back. So we've discussed the question, what do I have? What is out there? We've discussed the question, what do I have to do? But the million-dollar question is always in the clinic, how long is it going to take me to get back? Now, also there, we were humbled to say we really didn't know. And we tried to take it into our hands and be accountable for it and return the question to the player, saying our data shows this. And we've looked into 110 male professional football players in our cohort, so a very homogeneous cohort. And we've looked into the unstable ones, and we found that the return to on-field rehabilitation is around 37 days, return to train with the team is 72 days, and return to first match is 103 days. Now, that is, of course, much longer than the classic ankle sprain. And that also shows that we have to realize and immediately tackle the question saying, what you have is not the classic ankle sprain. What you have needs a bit of time, but we don't stop there. We need to get this down because this is too long. And that's where I want to share 2 slides with you on insights we received. So this is a video of a player that came into clinic and said, Doc, I have an ACL, can you fix it? But while we were investigating, he also said, can you look at my ankle on the ipsilateral leg? Because I really have pain there as well. Long story short, you see here the combination of a valgus trauma, external rotation, where you have an ACL and a syndesmotic instability. And that made us think. And it made us think and realize that there are striking similarities between ACL and syndesmosis, to an extent that we say now that the syndesmosis might be the ACL of the ankle. Now, why do I say that? Because if your full foot gets stuck into the ground and you have the valgus mechanism, you get the ACL injury of the knee. But if it's just a forefoot, you get the syndesmosis. So it's the foot position at impact or at stuck situation that decides which joint will be unstable. And we cover that argument or that hypothesis with a lot of striking similarities around bone bruising patterns on the MRI, the clinical testing, the kinetic chains, the rotatory constraints, and the mechanism of injury. I won't go into much detail there, but happy to tap into it during the discussion. And as I said, we see that we start to understand these injuries better. The data out there is now much more evidence-based, but we still don't have an early return to sport like the classic ankle sprains. And we believe that the key in that lies into the ACL rehab. And why do we say that? Because in the data that we see in our assessment labs, we see that if we cover the ACL rehab principles towards the syndesmosis, we get an earlier return to play. And we've actually published that together with 2 wonderful colleagues from the Netherlands, Igor Tak and Ali Gökler. And with their insights together, we share the principle around getting syndesmosis swiftly, but also more solidly back. And this is now something that our groups are all working on in order to tailor further and to make sure that we understand it better, but that we also get the treatment criteria better and more focused on that syndesmosis, where ACL is a big part of our thinking pattern. Now, before we tackle the last part of the question, re-injury, I want to share with you this video. What happens here? We always talk about diagnosis and clinical tests and imaging and types of treatment, whether it's fixation surgically or through physiotherapy, podiatry, and other means. But sometimes you just have to look in what's happening. Here, the player slides out. Okay, it's not a pure syndesmotic mechanism, but the surface friction between natural grass and artificial grass is very different. And during gameplay, these things happen. So sometimes our prevention, which is the number 4 question, is just in front of our nose. And for example, during the World Cup, what did we do? Because of this knowledge, we extended the natural grass for 5 meters in every stadium. And the data that actually is now out there and is published recently shows that, of course, it's not the only reason, but the injury rate related to variables like this is much less since that. So the message here is we have to focus on our medical and sports medical part, but sometimes we have to think a bit more outside the box and maybe not just talk with your doctor, with your podiatrist or with your sports physiotherapist, but also with your grass master. And more we see that pop-up companies and new interests show that it's probably more important than we thought to take this into account furthermore in the football. And with Kat here in the room, I wanted to stop the presentation on that, linking to the female foot, because thanks to Kat Attle Thompson and so many, how can I say, motivated people around, we have now finally a better insight in the female football foot. And as we know, there's a lot of ACL and syndesmosis in female sports as well. And with this new knowledge, we believe, and we already see that that with the new knowledge that has been extrapolated to new shoes, we already see that that will benefit the player injury and re-injury in female football as well. So in a nutshell, I want to finish that syndesmosis a few years ago was like getting the World Cup stadium in football first day in, and it looked miserable. It looked all over the place, and it looked like there was no systematic organization there. Well, nowadays, with the help of so many colleagues and interestees in the world, we have been able to clarify it, quantify it, standardize it, and make sure that we understand it better and extrapolate that to the better care to our players. Of course, it's a work in progress, but I think giant leaps have been given already in order to tailor to the 4 questions that our athletes have. A last video is on the striking foot of Lionel Messi during a training session. As you can see, the way he gives the free kicks is only how he can do it. But if you look at his standing leg on the right side during his strike, you will see, and I will go back with the video and loop it again, you will see he kicks with the left, but his standing leg is guiding the way he will kick, and he rolls it off much more than what we call a normal ankle stability side. Now, the message here is, as a take-home message, we work in elite football. If injuries occur, we have to make sure that we tailor our treatments to the demands of the player. If you give a rigid fixation to this foot in case of injury, you remove the absolute talented player with his particularities and the reason why he gets so super famous. So it is very important to understand the needs of the player and tailor our treatments to that. I want to thank you for the chance to join and give our insights and the recent research we had together with others on this topic. And allow me to, on behalf of everybody, already mention that it will be amazing to join and share more insights on all the topics around football in the elite football stage in Europe during the medical symposium in Lugano very soon. But I'm sure our team today will guide us more on that. We also have a surgical skills core in February in Doha. And with that, I'm heading back to you, Evert.
Thank you, Pieter. You're not heading it just back to me. Now the fun starts. Now we're going to pick your brain I'm going to get Adam in as well. I'm going to pick your brain too, Adam. So very insightful, Pieter. We have a few questions already burning on my mind to throw at you. But before I do so and get a discussion started, I'd like to invite everybody once again to put any questions, comments, thoughts, or whatever you'd like to share about syndesmosis injuries in the comments box. So we will moderate them into the discussion. Adam, can I start off with you, maybe asking you a question? Because Pieter showed us an increased incidence rate, which is still relatively low if we compare it to other injuries. Is this increase in syndesmosis injuries also something you see in your practical experience working with Everton or in football in general?
Yeah, I think Pieter's presentation was fantastic, and one of the points he made is definitely something that resonates with me in terms of that link between greater awareness of these injuries and potentially that increased incidence of. I think it is quite a fine line between the fact that we hopefully are now having more awareness of them and looking for them more, and therefore ultimately are diagnosing and rehabilitating more of them. So that was definitely a really strong point that I agreed with in terms of that. And I think that for me is definitely the case in what I see, and obviously with potentially more availability of kind of imaging, better quality imaging, things like that, again, really helps us to see these injuries more clearly and understand them and know what we're looking for and how to look for them. And when you're talking about things like X-rays as well, just having that awareness of having to do weight-bearing X-rays for these to truly see the extent of the injury. And again, maybe historically that isn't something we did. People might have just X-rayed and not known exactly how to look for them properly and really identify them. So definitely, I think we're seeing more, and I think it's a really valid point that's probably because we're looking for more.
Okay, so there's kind of two sides to your answer here. We are better in diagnosing them, so let's get back to that a little bit later. I'm also wondering, also because Pieter, you showed the football boots for the female player, for instance, because the foot differs. Might there be a relationship with surface conditions, development in shoes that may increase risk or expose to certain mechanisms that we see?
Yes, well, the two mechanisms are basically as we've shown, but what we see a lot as well is the typical pattern that you would say is linked to ACL. It's striking if you start looking into it, David. Now, for example, a striker that goes high against the goalkeeper for a corner kick and lands, if he lands on his forefoot and goes in external rotation, there's a full-blown syndesmosis injury where in many cases you see when the foot strikes, it's on ACL, and it has to do obviously with that proprioception, with that motor control, with that fast track activation of the muscle where fatigue comes in. We all know that the ACL, call it biotope there, is linked to preventing furthermore these type of injuries. Now it's exactly the same for syndesmosis. The problem is that there's not one muscle running around the ankle where it does around the knee. So that's the big challenge. There's only tendons around the ankle. So we are now working into understanding better how we could activate there faster in order to avoid, call it re-injury like an ACL would be, in these type of mechanisms. But long story short, you have three mechanisms: the jumping and landing, the foot that gets stuck without contact, but most of them are contact related, and the tackle from behind is still the most devastating one. And luckily that is now, for referees, a red card, but we still do see them a lot.
Jumping maybe a few steps, going towards prevention. There is a question in the chat about this, linking to your thoughts about ACL injuries. Adam, maybe you can reflect on this. This is about, should ACL protocols be implemented here to to potentially do something about these injuries?
Yeah, and I think again,
do you do it? Maybe that's the question. How do you tackle this?
I'd probably say not as specifically as kind of looking at it literally the same as that ACL, but I think there's obviously real similarities when, say, you are rehabbing the ACL and thinking about what support's being offered distally in that limb and the, like say, the proprioception of things. That still comes exactly into it because we're trying to prevent that exact foot posture that we believe will then help further up the chain at the knee. So definitely in terms of that, it would fit. And again, I would totally agree with Pieter in terms of the challenges around it in terms of prevention and therefore in terms of rehabilitating to prevent re-injury, because the foot is left so vulnerable in that position around the ankle, and to really strengthen that up is difficult. So we're looking at those non-contact mechanisms of injury and trying to educate around those and think about those within our rehab, and trying to then add in as we go those external factors, the kind of contacts at the last second just before you're landing, and trying to add in those things again exactly as you would within an ACL rehab, looking to introduce that kind of chaotic environment and making sure that control and stability around the foot and ankle is there, which will then ultimately help further the chain with the knee.
Yeah. But then maybe me thinking the wrong direction. Back at you, Pieter. You just said there's a lot of muscles around the knee, and a lot of the prevention programs we have focus on these muscles around the knee. There's less muscles around the ankle. Is it a bit of a weakest link issue here, that the more effective we get in protecting the ACL, the more risky we make, the joint below there?
Absolutely. And we've just started to throw out the hypothesis on the fact that, first of all, we start to understand the injury better, but we still don't rehab them faster. It's still way too long. And we see these striking similarities with ACL. That's where we are for the moment. We don't have the key to the solution yet, but we're gathering the data in order to hopefully filter the criteria around it that make sense and that are evidence-based, in order to come up with a protocol that is working better, because there's still a lot of re-injury, so that protocol is still not good, and they're still too long in rehab, according to all of our experts around the world. So these two questions, we're trying to understand better how to solve them. And that's basically where we are. And we believe that assessment labs are the key to guide us on how to do that furthermore. And we do believe that ACL has to be part of that, not as a key part, but for sure as something to take into account, where we can learn from that historical pathway towards better understanding in the same fashion as for the ankle syndesmosis. So this is where we are for the moment.
Yeah, fully understood. Makes sense to me. Anything to add to that, Adam?
No, I think, again, like you're talking about, the rehabilitation is taking too long. I would agree. I think that's, for me, partly because these injuries rehabilitate in such a different way. And I think part of that, again, a big thing when I'm rehabilitating these injuries is education, because educating early on about what the player or the patient is going to feel throughout the process. They will have episodes of pain, and we know with that external rotation mechanism, similar with the MCL at the knee, that there will be times when they catch a pass wrong or do something like that within their rehab, and it's painful, but that pain doesn't mean kind of structural damage. And I think that is potentially sometimes why these injuries take a bit longer, is it depends on the appetite of the player to work in pain and acceptable levels of pain, and understanding what that is. So that's very different for maybe doing a rehab session and they're sore for 2 days afterwards. That's not acceptable pain. But within a session, taking a kind of touch on their toe and opening the foot out and having a 10 to 15 second incidence of awareness, and then that settles down. Again, that for me in this elite setting would be acceptable. And I think it's how you navigate through that and give that player confidence to work through, because if they don't know that in advance, that they're going to probably have these things, then you're losing days and weeks at a time where they think that is a real negative. And it's about you educating that these things do happen. And every time you do it, it will get less and less because your body's adapting to those positions.
So it really requires a close process of rehabilitation, and it's really individualized in that sense. Right?
Yeah, definitely, and kind of as you would with a lot of rehab, setting out that kind of understanding and the goals with your athlete. I think if your athlete's goal is to be completely pain-free at all times, then these rehabs are going to be difficult and they are going to be long. But if they have that understanding of, as I say, what is acceptable and what isn't in everyone's eyes, in their eyes and our eyes, then hopefully that allows you to be a little bit more aggressive and trim some of the time off these rehabilitations.
Yeah, and the time off from the pitch and between injury and return to play is our common measure of how severe an injury is. So that makes a good sense. Obviously, rehabilitation starts with proper diagnosis of the injury. We already said it's sometimes under-recognized. We got some questions in the chat about diagnosing. Maybe I'll put this one on from Tim van der Hoek, or Jos van der Hoek in this case. Wrong name there. Physician from Feyenoord. They use ultrasound as a low threshold tool instead of X-rays. Maybe you can reflect on that, Pieter?
Yes, absolutely. And I mean, we're all clinicians, but I can confirm that there's absolutely no need for, let's say, immediate MRIs for these types of injuries. Absolutely not. Why? Actually, there's our fellow, Thomas Baltus from the Amsterdam group was with us and has published 2 beautiful papers and studies. The first one is that there was a high sensitivity and specificity for clinical testing in order to diagnose. And the second paper was on ultrasound, where he showed that ultrasound was, if I remember well, was actually superior towards MRI because of the dynamic status of that type of investigation compared to the static MRI. So yes, ultrasound has a big advantage, especially in the initial stage, to understand if there's something really bad going on or not. Is it bad or not? And then to identify whether the AITFL and the IOL are injured, because then you come into a grade 2 stage, and then you have to start working your way through that algorithm of diagnosis in order to know if it will be really stable or unstable, and then decide within the early time frame to the right treatment. But there's a few things here. When you talk about clinical testing only, we all think syndesmosis is a lateral injury, but believe me, the key is medial. The palpation of an injury where you want to know if it's bad or not, because that's what we all want to know. You're in the stadium or 1 or 2 days after the injury, the player asks, "Doc, something's going on, can you check?" Well, palpate medially, because if there's apprehension medially, whether it's in the medial gutter or over the deltoid complex, then a ring has to bell. A bell has to ring. So that's the inverse. So it's not lateral medial, it's the same. Long story short, palpate medial, because that's key to knowing if it's bad or not. The second one is radiation up. If you go from AITFL, you push upwards over 4 to 5 centimeters, and on a weight-bearing moment, there's shooting pain up, together with your 2 tests that are kind of the tests for syndesmosis on the lateral side, which is the external rotation test and the squeeze test. So you work your way through, you start medial, you go on the radiation up, and then you do the 2 tests. And then you have a very good insight clinically whether this is going to be more stable or unstable. That's the first thing. And then the second one is the ultrasound, where you go in dorsiflexion, external rotation, you mimic the mechanism, and you see if you have that opening of the tibiofibular overlap space and the medial one. You can perfectly see that. And now the data shows that it's actually evidence to do that. So yes, and long story short, yes.
Good. Thank you. Adam, back to you. There's also a question in the chat. I will pop it up in a second in relation to this. How do you deal with these on the pitch when you see them? What is your experience?
Yeah, so I think these are kind of challenging on the pitch as well. And obviously, if we're seeing a kind of a big tackle from behind, exactly as shown in the video, quite a traumatic mechanism, you're generally going to know pretty quickly that this is a significant injury, stabilize and remove with stretcher, because again, with the anatomy, every step that we're taking, we're causing gapping at that distal tibiofibular joint. So we want to minimize that, immobilize it as soon as possible. Again, where alarm bells will start to ring for me and high index of suspicion for the kind of lower grade or moderate grade 1s and 2s is where someone's had a mechanism and they kind of take a little bit of time to get up and maybe start going again. And then 30 seconds, 45 seconds later, they're sitting down on the pitch because something's just not quite right. And it's probably not like anything they've felt before, because it's not the classic lateral ligament injury. And again, that would be when I'd be always looking to kind of rule these injuries out on the pitch, where, like I say, it feels okay when they're laid down. As soon as they get back to weight bearing and maybe they go to do that first sprint or first jump and they land, something's not right and they can't figure out quite what it is that isn't right, and they maybe verbalize it quite poorly. But again, then I'd be looking straight away to try and rule that syndesmosis out immediately on the pitch.
So you kind of have the assumption there that probably an ankle sprain they've experienced before, so they can tell me what happened. But with a syndesmosis injury, it's a bit more tricky for them to verbalize.
Yeah, and they might, again, with a lateral ligament, they might have quite an obvious sharp mechanism. But again, sometimes with these syndesmosis, they've gone into a slightly awkward position and they're not quite sure. Maybe this just feels like that because I've gone into this strange position. And then the longer they go, it's not clearing up how they would expect it to, and they're struggling with function. And yeah, definitely that would be the sort of pattern that I would see with these low to moderate grade ones.
Yeah. So probably then the question I'm going to put up now, it's kind of in relation to this, to the diagnosis. It's going to be an obvious answer, I think, whether we should rule out syndesmosis injuries first before we start management of ankle sprains. Especially in the case you just described. Probably you don't really know what happened. The player can't really verbalize it. So there are some red flags. How do you approach this, Adam?
Yeah, so I would totally agree with that, in terms of we're much better anything that we get around the ankle in terms of kind of lateral pain or anything like that we're seeing. The sooner we can rule this out, the sooner we can have confidence that it's not something as severe. And again, as touched on in the presentation, if we miss these for whatever reason, whether that be really acutely on the pitch or whether that be within our clinic, kind of in those days afterwards, and we don't manage it correctly early, then you're fighting a real battle with these, because they're not going to behave how we think. We're adding more and more trauma to it, and our chances of having a real positive, successful, smooth rehabilitation are minimizing literally with every step that we're letting them take after that. So again, if we can always have these injuries in the forefront of our minds, and it takes us 1 minute to kind of clearly rule them out or have them within our differential diagnosis, then that would definitely be always the route I would take, because you're much better off spending a minute, 2 minutes on every ankle you assess, ruling them out, than missing the one and having to deal with the consequences of that within the rehab and the management.
Yeah, that's a sensible answer, I think. Pieter, can I move this question to you a little bit, because you're in the clinic, you probably get asked to diagnose these injuries based on the fancy tools you have available there. Do you think you see enough of them, or do you think the referrals are still under average, and you would need to see more of these injuries?
Yeah, well,
confirmed?
if I can tap into what Adam said, I agree. And nowadays, luckily, wherever you are in the world, in official competitions, you get the chance to look at the mechanism of injury. It really helps you if you can have your hands on the video. Now, as you've seen in the presentation, epidemiology of what we saw is that most of them, of the syndesmotic injuries, occur during match play. So that's the advantage. We normally get our hands on the feet of the injury mechanism. And I think that works incredibly well for us, for the simple reason that, as Adam said in the beginning, that lateral complex of the ankle, whether it's an ankle sprain or so-called high ankle sprain, or a subtalar pain, or whatever of anterior lateral impingement you have, it's all in the same area of pain. So you can't really know. You have to wait. Now, with whether you have tools or not, it doesn't really matter, as long as you can try to find the keys. And for me, the mechanism of injury really works. That guides me from the start. So that's the first thing. And then, of course, it's always good to have some extra rings and bells around it. But actually, where we work, we've inverted it, because we see in many centers that the moment syndesmosis comes into the picture, very fast and in a swiftly manner, it becomes a surgical consultation, which is striking because most of them, of the grade 2s, they heal without surgery. Now, and that's where we went back to our cadaver lab and to our mechanism of injury, and we've actually created and worked with our physiotherapists to a non-invasive tool in order to know if it's stable or not. But that takes us a bit too far away. But we've inverted that process. We've actually gone more conservative, because if we can really find the ones that need it and rehab the ones that don't need it without surgery, you actually make an athlete much happier, of course. Yeah. So we've seen that as a gap that we're trying to bridge, and it works for us. And that's something that when you talk with your peers around the world on it, many people are still looking for that in order to know, okay, it's stable or not, but what do we do? And of course, rehab is, whether you do surgery or not, the key. But when you talk about surgery itself, it has gone through a huge evolution as well. Previously, we've put screws in. That's nowadays not necessary in isolated syndesmosis injuries. Then we've put suture buttons in the ropes, which do very well for compression, but they don't hold the rotational stability. So now we combine the suture button rope, call it, together with a repair of the AITFL itself. And we see now that that works very well. So also, not just from a rehab point of view, but also from a surgical point of view, we've gone from far. And we see now that we really, together with the insights on the rehabilitation linked to whether it's ACL or others, we're getting our athletes not only structurally better, but also faster better.
Yeah. And I don't think this is too far off track, because there's another question burning in the chat, which is about the decision making between conservative versus surgical management. I think you answered 90% of this question already, Pieter. Is there anything else to add, how to make that decision, or how you would make that decision?
4 things, if I can say. First, palpate medial. If there's apprehension, alarm on. Second, radiation up from AITFL to 3 to 5 centimeter up during weight bearing. Third, positive external rotation test or squeeze test, one of the two. And fourth, do an X-ray. And of course, if you have some widening, which is not always the case, but these 4 guide you towards stability or not in the classic setup. And you don't need any specific tools for that, except for the mechanism itself. I always start with the mechanism. I really take my time to understand. Many times the players don't know what happened. And then I say, show me. And we just go out and we try to get back to the mechanism. It is the guide for me in pathology like that.
Yeah. That brings me a little bit to the last webinar's topic, which was communication and multidisciplinary teams. That is a key here then as well, Adam, right? That you know what happened on the pitch, and you can communicate that potentially with a surgeon.
Yeah, and I think again that communication is massive, and because these injuries are in terms of decision making, exactly like we've discussed, grade 1s and grade 3s are relatively straightforward in terms of which route we're going to take, and those grade 2s are so up for debate in terms of what we're seeing on the bed, functionally, on various different types of imaging, dynamically in terms of ultrasound or weight bearing x-rays and in clinical testing. I think that's where communication really comes into it, again, in terms of setting appropriate time limits and understanding what that is showing us. So if we're taking someone out of the kind of protective boot too quickly, and then they've still got symptoms, and then we're thinking, right, this is kind of failed conservatively, we're going to have to go surgery. Again, has the communication failed there in terms of what's actually needed biologically to show that we've protected it for long enough? Have we kind of reassessed the stability of it? Because again, pain doesn't necessarily mean instability. And again, I think the real communication is vital in terms of making sure a real obvious plan and correct plan is set out so that we know we're making the progressions at the right time. And if we see something that doesn't fit with what we've communicated in terms of physio, doctor, surgeon, consultant, then we're acting on it at the correct times, and we're not jumping the gun kind of one way or the other, and maybe not leaving them in the boot so long that we don't actually know what's happening with them and how they're progressing, and we're just going so safe and conservative that actually we don't give them a chance to find out whether that's the appropriate mechanism. So yeah, for me, communication is vital in terms of making sure we've got clear, obvious timelines, goals, kind of check-in points to make sure that we're reviewing it at the right times to give us the information that we need to make the correct medium to long-term decisions.
Yeah. Well, that brings me to another question. You said the word weight bearing a couple of times. There is a question in the chat. This is after weight bearing after surgery, of course, the question, but maybe in general, can you give an indication, Adam, of how you deal with the timing of weight bearing in your approach? And then I'm going to ask the same question to Pieter from the more surgical standpoint.
Yeah, so I think it's really interesting, and this is where some of these injuries are so different in terms of weight bearing. So yeah, in the acute phase, we'd have them in that protective boot, making sure they're not going into dorsiflexion to kind of really stress the healing structures. But again, I like to use a lot within my rehab, almost like that zigzagging my way out of things. So when they come out of the boot, for me, that doesn't mean they're right and they can all of a sudden just start weight bearing fine. It's how then we use kind of compressive strappings to provide that compression, reinforce what we want these syndesmotic structures to be doing. We can't just expect them to come out of a boot where they're not going to any dorsiflexion and suddenly walk. And again, how can we do that? Can we use a lot of kind of time-based measures? So we might get them out of the boot whilst they're at the training grounds and have that compressive strapping on, reinforcing the syndesmotic structures before then putting them back in the boot when they're away from the training ground. So we've got that little bit of control about what weight bearing we know they're doing, because we know within the training ground they're only going to go in certain confines. A lot of the time it's going to be on one level. We're not going to go up and down stairs, versus going into the kind of big wide world where they're then weight bearing on and off kind of more unstable surfaces and having to challenge in that way. So that for me is the first part of return to weight bearing, is not just going from 0 to 100 and making sure we're using strategies to manage exactly what those structures are having to tolerate. And then also within the gym, again, thinking about what these structures do and when they're stressed, mostly being stressed in dorsiflexion and external rotation. There is actually loads that we can do in the gym relatively early if we're working in plantar flexion. Again, with, as I said, that supportive strapping, there's lots and lots we can do. And again, when we think about return to running, going past that weight bearing, but what is that ankle doing? So these are kind of non-traditional rehabs versus, say, our muscles, where they like running quickly early because they're generally quite stiff within the ankle. They're having to tolerate that quicker running. These don't like that ploddy, slow running where they're having to go all the way through range. It's really going to stress them. So again, these are injuries where I think you have to be so specific to what the role of that ligament is. It's not just a case of, say, with a lateral ankle ligament, you just want a straight line run. You want to think about what running you're prescribing, making sure there's no decelerations, and thinking, to go back to the question, what weight bearing are you putting it through, and in what ranges are you putting it through?
So the answer is it depends.
Yeah.
Really short summary of it.
Yeah.
Yeah. It's a tricky injury. It's really difficult to find the right tune for each individual player, of course, because there's so much going on. Another question for you, Pieter, and then I think we need to round it up a little bit, also given time, is on the use of injections in this case. Probably that's a question you get asked sometimes as well. Can you share your thoughts on that? And then I will ask you both. You can start again already to think about it, Adam. So three take-home messages from your perspective for the audience. But Pieter, first this question.
Yeah, sure. Well, we follow the data, and the data shows that there's no room for orthobiological injections at this stage in the knowledge we have on this for AITFL or IOL. I think that the major message here is plaster is disaster. Never immobilize, because it doesn't work and it gives much more re-injury, because that fibrosis is not what you want. You want something that is elastic, something that does the job well. Now, whether you go conservative or surgical, the main issue is that you immediately can allow weight bearing in a boot, for the simple reason that if you understand the injury well, what happens is that you have the fibula and the tibia, and people think it just widens. It doesn't. It widens and it goes backwards. So it is this book mechanism that has an unstable mechanism of the syndesmosis. So if you want to fix that, you bring it back and you hold the rotation. And with that, if you go for surgery, you fix it in that fashion, and then the rehab is very clear. You wait until 6 to 8 weeks before deceleration and cutting movements are allowed. You give that structure the time with the intrinsic stability give during surgery, and with the surrounding support of the rehab. It's just enough to start off then, but not before. And what we like to do in a conservative way when we don't go for surgery is the supramalleolar tension strapping. It's a type of taping that really works well and that we use after 3 weeks. We get out of the boot and we really start with that taping to do a bit more of the teasing exercises. So these things can help, but no evidence for injections, for sure no evidence for immobilization except for boot and gradual progress, and taping really works.
Those were your 3 take-home messages already.
Yeah, I got them.
Isn't it? Okay, you got them in. Adam, from your perspective as a therapist working on the pitch with the team, what are your 3 take-home messages for your fellow colleagues on this call?
Yeah, so I think my first one we've obviously touched on is just, it sounds stupid, but don't miss them. So make sure you've always got that massively high index of suspicion for these, based on exactly as we've discussed, mechanisms, the fact that they may not fit our pattern. So the sooner we can diagnose them, the better, because then we're putting in the correct kind of management strategies as early as possible, and that gives us the best chance. I think another thing is not to be scared of them. So kind of as we've just talked about, that immobilization, we don't want to just leave them immobilized and think that's going to do our job for us. So really thinking about what can we do and having that kind of positive attitude towards them, providing tissues need load to heal. So the sooner we can provide appropriate load, the better. And then my third one, again, as already touched on, is for me, education. If you can educate your player early about what they're likely to feel and what is normal and what is not normal for the rehabilitation process, then you've got a much better chance of a successful outcome without having to kind of dip away and drop off the rehabilitation as you go.
Yeah. No, those are really practical take-home messages, and I think a lot of people will be helped by that. Not only colleagues, also players, I might say. Yes. Thank you both. This hour flew quickly past. There were still a few questions in the comments. We need to keep those for a later date, I'm afraid. I'm sure we haven't talked the last about this injury. There's definitely more to say, especially with all the work that's being done by your group and the Amsterdam group, Pieter, and your collaboration there. Also by your practical experience, Adam. So probably this is an open invitation to get you back on this screen for another hour talking about this. While we're at it, you can see on the bottom of the screen the UEFA Medical Symposium coming by. It's also in the comments in YouTube. These injuries will also have a place on the program there to a certain extent. So please join us there in Lugano in Switzerland in February 2025. And then before we all log off, and before I let Adam and Pieter go to their well-deserved evening, our next medical webinar is in November 25th, if I'm not mistaken. I just saw the date go by, 25th, and it's on mental health in football. And we have two amazing speakers. We have Fran Chem from Liverpool FC, and we have Vincent Kutebarge from FIFA, and we'll guide you through mental health in players, but also in relation to injury and rehabilitation and successful return to play in park. So hope to see you all then. And again, Pieter, Adam, thank you, and have a nice evening. Bye-bye.
Pleasure.
Thank you.